The diseases, the periapical pathologies that are discussed in this video are apical periodontitis, periapical abscess, periapical granuloma, periapical cyst, condensing osteitis, and periosteal ossificans. So let me show you an attempted graphic of how an apical periodontitis evolved. So this is a mandibular first molar tooth, and what you see here as the black line is the supposed to be the periodontal ligament space, and the white line that will be seen next to the periodontal ligament space is the lamina dura, which represents alveolar bone proper. So this is a pulp chamber, supposed to be the pulp chamber and the root canal. And when there is a microbial invasion in the form of caries, which involves the pulp chamber, it can cause pulpitis and pulpal necrosis. So the necrosed products from the root canal reaches the periodontal ligament space at the apex, which causes inflammation and accumulation of edema. This accumulation of edema pushes the tooth towards the occlusal surface, resulting in the extrusion of the tooth from the socket. This pathology is called as apical periodontitis. So apical periodontitis results from the necrotic product released from the infected canal, and the clinical features include the pain, which is the dolor, mild tooth extrusion from the socket because of the edema, inflammatory edema, that is called as the tumor, and patient avoids biting on the tooth. That results in the loss of function. What is the problem here is because of the extrusion of the tooth above the occlusal surface, when the patient attempts to bite on that side, the first tooth to make a contact will be the offending tooth. So this offending tooth will be pushed towards the inflamed periapical region that may evoke a painful response. So patient avoids chewing on that side. So this results in unilateral chewing habit if it is a posterior. And if you percuss the tooth with an instrument, the vertical percussion may result in a painful response. And the other signs of inflammation like calor and rubor, that is the heat and redness, cannot be appreciated as the whole problem occurs within the confines of the jawbone. What are the radiographic findings you will be seeing in apical periodontitis? The crown may show a radiolucency representing caries, or a radiopacity representing the filling, or a fractured crown. The lamina dura, which appears as a white line, will be intact throughout, but there will be thickening or widening of periodontal ligament space at the root apex. Now let me show you a radiograph. Here is a patient where you can see the left maxillary central incisor is having a mesioproximal restoration, and there is a radiolucency below the restoration representing secondary caries, and the tooth was symptomatic. Patient had pain, and there was pain on percussion. And look at the apex. The lamina dura will be intact, but there will be a thickening of periodontal ligament space at the apex. And if you start a root canal treatment in the form of access opening and relieve the pressure, the reduction, the drainage will cause decrease in the pressure by the inflammatory edema, which results in the disappearance of the thickened pedial space. So this is how an apical periodontitis looks like in a periapical radiograph. And this is a closer view where you can see the lamina dura will be intact, but there will be thickening of pedial space, suggestive of apical periodontitis. This is another IOPA radiograph, intraoral periapical view, where the first molar is showing a metallic restoration, and there is a distoproximal radiolucency suggestive of secondary caries in very close to the pulp chamber, and the mesial root is showing the intact lamina dura and the thickened periodontal ligament space at the root apex. Similar change here on the second molar, where there is a coronal radiolucency representing dental caries involving the pulp chamber, and there is thickening of pedal space on both mesial and distal root, suggestive of apical periodontitis. You should be very careful when making a diagnosis of apical periodontitis in the maxillary posterior region, that is from the maxillary premolar and molar. There could be a possibility of overlapping of maxillary antrum over the pedial space at the root apex. So this may give a wrong impression, looking a similarity, wrong impression like apical periodontitis. Radiographically, it may look like a apical periodontitis, but a simple pulp vitality test would differentiate the both. If it is a maxillary overlap, the tooth will be vital, and if it is pulpal necrosis and apical periodontitis, the tooth won't respond to the pulp test. Now, the second pathology that we are going to discuss is periapical abscess. When the necrotic product reaches the periapical area, two important factors play a role. One is the virulence of the microorganism, another one is the host defense. If the virulence of the organism is high and the host defense is less, then it may lead to frank suppuration and accumulation of pus at the root apex, called as periapical abscess. Regarding the clinical feature, there can be acute periapical abscess and chronic periapical abscess. And the second finding will be there will be a source of infection in the form of dental caries, large restoration, and trauma in the form of discolored tooth or fractured tooth. The next clinical finding will be pain. Pain will be severe in acute periapical abscess, and it will be dull and intermittent or absence of pain in the case of chronic periapical abscess. Pain on percussion will be present in acute periapical abscess, and there will be tenderness on palpation over the periapical region. Near the gums, when you palpate, there will be pain, painful response. Intraoral swelling will be present, may be present in acute periapical abscess. Intraoral or extraoral sinus will be present in the case of chronic periapical abscess. Sometimes we will be able to see a small hyperplastic mucosal mass around the intraoral sinus opening, which is called as varus. How periapical abscess appears in a radiograph? The crown may show radiolucency in the case of caries or radiopacity in the case of a filling or a fractured crown. The lamina dura at the root apex will be lost. There will be loss of continuity of the lamina dura at the root apex, and there will be a periapical radiolucency present at the affected tooth, and it will have an ill-defined margin. It will have an ill-defined margin, and there will be gradual widening of adjacent pedial space. It is not at the root apex, it is the adjacent pedial space, and size of the radiolucency usually will be less than 1 centimeter. So these are the radiographic criteria. So let me show you a graphical representation how a periapical abscess can evolve. So imagine this is a mandibular first molar, and you have the two roots, the pulp chamber and the root canal. And when the caries affects the pulp chamber, it results in pulpitis, and the pulp will go for necrosis. And once it is necrosed, the necrosed products are released to the periapical area. And if the host virulence, the virulence of the microorganism is more and the host defense is less, it may result in the formation of a periapical radiolucency, which have ill-defined margin or irregular margin. There will be loss of continuity of the lamina dura. This is how a periapical abscess evolves. Now let me show you a radiograph. Here you can see in the crown there is fracture of the enamel. Here you can see horizontal split in the cervical region. And if you move towards the periapical area, there is a periapical radiolucency, which is having an ill-defined margins. And the lamina dura, which starts from here, is lost towards the apical 1/3 of the root. Okay. So the findings are loss of lamina dura at the root apex, and there is gradual widening of the pedial space. If you see from here, the pedial space will gradually enlarge towards the periapical area, and the periapical radiolucency will be ill-defined, and the size is less than 1 centimeter. So these are the radiographic criteria for a diagnosis of periapical abscess. Almost similar change you can appreciate in the lateral incisor also. So the size criteria is very important. Usually it will be less than 1 centimeter. Another radiograph showing a gross decay in the mandibular first molar, and there is a huge periapical radiolucency with ill-defined border, and the tooth was asymptomatic. It's a chronic infection, and there is an irregular radiolucency for the periapical area, suggestive of a chronic periapical abscess. As I told you previously, a chronic draining intraoral sinus may produce a hyperplastic mucosal mass called as parallus. Here you can see there is a large restoration, old restoration, and with discoloration, and there could be a long-standing intraoral sinus, and the tissue has gone for hyperplasia. It's called as parallus. Here you can see 2 parallus associated with the gross decay of the primary molars, maxillary molars. Sometimes instead of intraoral sinus, a chronic draining periapical abscess could produce a sinus outside. So here you can see there is a extraoral draining sinus with the puckering of the skin. The skin is pulled inwards. So what we have done is we have tried to insert a Gattapacha point through the sinus, and there was a grossly decayed maxillary first molar was there, and when we tried to insert the GP point through the sinus, it went without any resistance, because by definition a sinus means a pathological tract that connects a pathological cavity to the exterior. So if it is a tract, the GP should go without any resistance. So it went without any resistance, and the IOPA shows that the GP point or the Gattapacha point went inside to the periapical region of the distobuccal root of maxillary first molar, suggestive of a chronic periapical abscess with a draining extraoral sinus. Now the third pathology that we are going to discuss is a periapical granuloma. As I said earlier, once the necrotic products from the infected canal reaches the periodontal ligament at the apex, the 2 factors, the virulence of the microorganism and the host defense. So if the virulence is less and the host defense is high, what will happen? It may result in the formation of a granulation tissue, collection of granulation tissue at the root apex, and the ensuing condition is called as periapical granuloma. What are the clinical features of periapical granuloma? There will be a source of infection, as discussed earlier, and the tooth will be asymptomatic. That means there won't be any pain on percussion, there won't be any tenderness over the periapical region, and there won't be any swelling clinically. There won't be any swelling or draining sinus will be there. So it will be totally asymptomatic. Radiographically, as I said previously, the crown may demonstrate a source of infection. There will be loss of continuity of lamina dura at the root apex, and periapical region may show a well-defined radiolucency with complete or partial corticated or sclerotic border. And there may be a gradual widening of adjacent pedial space, and the size of the radiolucency will be less than 1 centimeter. Now, here I show you 2 cases where this one is a central incisor, which was earlier treated, but without good obturation at the apical 1/3, which has resulted in a periapical radiolucency. Here you can see it is a well-defined radiolucency. Margins are very clearly seen. The size is less than 1 centimeter. Similarly, here a tooth which was traumatized has resulted in a well-defined periapical radiolucency, and here you can see there is loss of lamina dura, and there is a gradual widening of the peridial space towards pathology, and the size is less than 1 centimeter. Now let me compare the appearance of a periapical abscess and periapical granuloma. So here you can see the size is less than 1 centimeter, that is common for both, but the margins are irregular here or ill-defined here. Here it is well-defined. And loss of lamina dura will be present on both sides, and gradual widening of peridial space also will be present on the both sides. So the main differentiating feature between a granuloma and an abscess will be its margin. If the margin is well-defined, may show partly sclerotic border in the case of granuloma, whereas ill-defined and irregular border in the case of periapical abscess, chronic periapical abscess. So if there is a chronic periapical infection at the root of maxillary, premolar or molar, which is in close proximity to the maxillary sinus, sometimes it can remodel the floor of the maxillary sinus. Here you can see the floor of the maxillary sinus. You can see an remodeling of the floor of the maxillary sinus, which may result in a condition called as antral halo. Antral halo. And periapical granuloma clinically is a collection of granulation tissue attached to the root apex. So this is a classical periapical granuloma attached to the palatal root of a maxillary molar. This is a patient where you can see a gross decay in the occlusal surface involving the enamel and dentin and in close proximity to the pulp chamber, and the periapical area shows loss of periapical bone on both mesial and distal root. Here you can see the margins are well defined. You can see partly the sclerotic border, and the pathology or the radiolucency extend towards the furcation also, shows furcation involvement, more or like an endoperial lesion. It looks like an endoperial lesion. So what I did is started a root canal treatment, did the pulp extremation and biomechanical preparation, gave the intrapulpal dressing, left it for some time, allowed the periapical lesion to heal. Here you can see there is a remodeling of the bone, and gradually new bone started forming. And this is after a few months of follow-up. There is almost a complete resolution of the periapical lesion, and the furcation area, the bone remodeling is in the progress. So if the source of infection from the root canal is removed, there is a possibility of a periapical pathology to go for complete remodelation. This is the concept behind non-surgical endodontics. Now let me show you how a periapical cyst evolves with an animation. So again, a mandibular molar teeth and pulp chamber and the root canal. When the caries involves the pulp, it goes for pulpitis and necrosis. As the necrosed product reaches the periapical area, it can result either in periapical abscess or periapical granuloma, and a long-standing periapical granuloma can evolve into a cyst. Okay, so the cyst will have a well-defined periapical radiolucency, and there will be loss of lamina dura. The borders may show a white sclerotic border. Okay, the main difference between a periapical granuloma and a periapical cyst is the size. If the size of the periapical radiolucency is less than 1 centimeter, we prefer more of periapical granuloma. If the size is more than 1 centimeter, we radiologically prefer, the chances are more for periapical cyst. Now, what are the clinical features of a periapical cyst? There will be a source of infection, always in the crown in the form of dental caries, filling, discolored or fractured tooth. Absolutely, there won't be any pain. So, cyst is not a painful condition unless until it is secondarily infected. Extraoral swelling will be there, and intraoral fullness of the buccal sulcus or labial sulcus will be there always. And if palpated, cyst will have varied consistency. It can be soft, it can be cystic, it can be eggshell crackling, and it may show fluctuation. Pain on percussion will be absent, and tenderness also will be absent. If you aspirate, try to aspirate a cyst, you may get yellow color, straw colored fluid in a periapical cyst. Radiographically, there will be loss of lamina dura at the root apex. There will be a periapical radiolucency, and the radiolucency will have a well-defined border with sclerotic margin, and there will be gradual widening of peridial space, adjacent peridial space, and the size is more than 1 centimeter. So now let me show you some radiographs. Here you can see the maxillary central incisor, and the lateral incisor is involved by a periapical radiolucency, well-defined unilocular radiolucency, homogeneous radiolucency, and showing sclerotic white border. And the shape is almost like a round. Here you can see similar periapical radiolucency. It's an occlusal radiograph where we can see an ovoid radiolucency, again well-defined, unilocular, homogeneous, partly showing sclerotic border. So here it is round in appearance, here it is ovoid in shape. Another two case where you can see a large periapical cyst in the maxillary anterior region. Periapical cyst is very common in the maxillary anterior region. Okay, it is one of the odontogenic inflammatory cyst. Most common odontogenic cyst is periapical cyst, and it is common in the maxillary anterior region. Another occlusal view showing the classical appearance of a periapical cyst. So this is a case where you can see there is a periapical cyst associated with the maxillary right central incisor, and the root canal treatment was initiated, and BMP was done. All the necrotic products were removed. Okay. And if there is a periapical cyst, as I told you earlier, there can be extraoral swelling, and there can be obliteration of the labial sulcus. And on palpation, if it is very cystic or if it is showing eggshell crackling, we can attempt an aspiration. The aspiration may show you yellow colored, straw colored cystic fluid, which may have glittering cholesterol crystals, which is very typical of inflammatory odontogenic cyst. And the earlier case, which was surgically opened for enucleation of the cyst, and the canal was obturated, over obturated. These are the GP points that is visible there. After enucleation of the cyst, obturation was done, and this is almost 2 months post-operative follow-up, where we could see the periapical radiolucency has decreased in size, but still there is something remnant periapical radiolucency is there. Could be because of surgical defect or the scar that is found there. This is surgical enucleation of a periapical cyst associated with a root stem, the procedure, how it can be enucleated. Here you can see the cystic cavity, which is almost very close to the maxillary antrum. So this is how a periapical cyst will appear, and it should be managed. Now the next periapical pathology that we are going to discuss is condensing osteitis or sclerosing osteitis. So the radiographic features include the source of infection usually will be there in the form of caries, filling, or a fracture. There will be loss of lamina dura at the root apex, and there will be gradual widening of the peridial space, adjacent peridial space, and there will be a diffuse periapical radio opacity surrounding 1 to 2 millimeter or more of periapical radiolucency. The size may vary from millimeter to centimeter. So let me show you a IOP radiograph. Here you can see there is a coronal radiolucency involving enamel, dentin, and the pulp horn, distal mesial pulp horn. And there is loss of lamina dura, and there is gradual widening of the peridial space here. Okay, and there is around 1 to 2 millimeter irregular periapical radiolucency is there, but this is surrounded by a large area of dense sclerotic bone. This is what is called as condensing osteitis. It is a diffuse radiopacity, periapical radiopacity, both on the mesial as well as on the distal side. This is called as condensing osteitis. So what is the inference we are getting? The bone in that area, the jawbone, is defending itself and preventing the spread of infection from the periapical area. So it shows a good healing response, defense response of the bone to the periapical infection. Here you can see the extent of the sclerotic bone there. This is another case where you can see the mandibular first molar. There is disto-occlusal caries involving the pulp chamber, and there is irregular radiolucency and a large diffuse area of radiopacity, suggestive of condensing osteitis. Now, the last pathology that we are going to discuss is called as periostitis ossificans. This usually occurs in children with good reparative response. So, the periapical infection producing a periapical pathology, and usually it will be a chronic process, and it results in the suppuration. The suppuration lifts the periosteum, and the periosteum forms a new layer of bone. Okay, after that the infection subsides. Again, it will be reactivated. It lifts the periosteum, produce a second layer of new bone. Like that, it may result in multiple new subperiosteal bone formation outside the normal cortex of the jaw. This results in onion skin appearance. Such an infection is possibly arise from the periapical infection of molars, extracted site, periodontal infection, fracture site associated with the buccal bifurcation cyst, developing tooth follicle, unerupted tooth, pericoronitis, or sometimes idiopathic. This is very common in mandible. Here I show you two cases: young boys with swelling in the mandible, and both were having grossly decayed first molar. Here it is grossly decayed. Here temporary restoration has been done there. So the radiographic, based on the radiographic appearance, this condition is classified as type 1 and type 2 by Kwai et al. Classification of periostitis ossificans. So the basic difference between type 1 and type 2 is the cortical outline, the cortex. The cortex will be maintained in type 1 and it will be lost in type 2. So in type 1, subtype 1, there will be a single lamellae of new bone will be there. Whereas in type 2, there will be fusiform bony expansion with trabecula running perpendicular to the cortical outline of the mandible will be present. So let me show you here. Here you can see the right mandibular molar is grossly decayed and there is a huge periapical radiolucency there. Let me show you a closer view. Can you able to see a change here? Let me go closer. So this is the offending tooth. There is a coronal radiolucency. There is a periapical radiolucency on both mesial and distal root. And here you can see a new layer of subperiosteal bone outside the lower border, cortical lower border of the mandible. Okay. The patient on the second patient, again we will go have a closer look. The temporary filling is in the place, and there is periapical radiolucency over the mesial and distal root, and there is a fusiform bony swelling outside the cortical lower border of the mandible. The occlusal view of the same patient showed two lamellae of new bone, and here you can see 1, 2, 3 layers of the new bone formed outside the normal cortex of the jawbone. So giving the characteristic onion skin appearance. They say this is the onion skin appearance of periostitis ossificans, popularly called as Gary's osteomyelitis. It is very common in children who is having good reparative capacity. So there is another name for this called as chronic osteomyelitis with proliferative periostitis. So once the source of infection is removed, there will be gradual, slow remodeling of the bone. And these two cases have been published as a paper by me and my colleagues. The title is Periosteal ossificans, radiographic study of two cases. It was done in the year 2006 in International Journal of Pediatric Dentistry. So the final message is the periapical pathology based from the pathological concept. From the pathological concept is divided into apical periodontitis, early stage of periapical abscess, chronic periapical abscess, a periapical granuloma or a periapical cyst based on the size, and the last one is condensing osteitis. Now let us have a discussion about a relatively recent classification based on clinical findings proposed by American Association of Endodontists and American Board of Endodontics. So they divide the diagnosis, endodontic diagnosis, into pulpal diagnosis and periapical diagnosis. So under the pulpal diagnosis, they have different options. One is normal pulp. Second one is reversible pulpitis. So what is reversible pulpitis? When there is a thermal stimuli in the form of a cold or heat is applied, there will be transient painful response which will last for a few seconds and it will subside. When the stimuli is removed, usually the pain response will subside. Then we diagnose that as reversible pulpitis. The next one is symptomatic irreversible pulpitis. Here, when a thermal stimuli in the form of cold or heat is applied and the stimulus is removed, but there will be lingering pain for more than 30 seconds. Patient will feel there will be continuous painful response for more than 30 seconds. Then we will say it is irreversible pulpitis. The next is asymptomatic irreversible pulpitis. When we try to remove a caries or a restoration and we know that it can result in an intentional pulp exposure, we can call that as irreversible pulpitis. And the next one is pulpal necrosis. Here, there won't be any response to thermal stimuli. So, pulp and periapical pathology are not different diseases. They are the different stages of the same disease. Okay. So, when the caries involves enamel and dentin, when the caries involves enamel, there is no symptom. When the caries involves dentin, there may be sensitivity. But when the caries involves the pulp, it can cause inflammation of the pulp that we call it as pulpitis. In the earlier stage, it may be reversible. We call it as reversible pulpitis. The next stage, it becomes irreversible. And finally, because of increased intrapulpal pressure, the blood supply to the pulp may be strangulated at the apex and it results in pulpal necrosis. Once the pulp reaches this stage, it won't respond to the thermal stimuli. And this necrotic products of the pulp necrosis, when it reaches the periapical region, the next stage of periapical disease starts. So the possibilities of periapical pathologies or periapical diagnosis are normal apical tissue. So there is no problem with the periapical tissue. Only there is a pulpal problem. Next is symptomatic apical periodontitis. Symptomatic apical periodontitis means our apical periodontitis. There will be symptom to the patient. Patient will have pain. Asymptomatic apical periodontitis. This is almost analogous to the pathological classification of periapical granuloma or condensing osteitis, where there won't be any symptom to the patient, but there will be a periapical change. So, asymptomatic apical periodontitis. Next is chronic periapical abscess. Chronic periapical abscess, there will be periapical radiolucency and there will be an intraoral or extraoral draining sinus material. Acute periapical abscess, see, acute periapical abscess and symptomatic apical periodontitis are almost similar. They may or may not show widening of radial space. In both cases, there will be severe pain. Patient cannot chew on that side. Okay. And last is condensing osteitis, which we have already discussed. So these are the possible periapical diagnosis, and these are the possible pulpal diagnosis. And both this association has come out with this classification for a purpose. What they claim, they are telling there is a need for simple, practical, universal classification system of endodontic diagnosis that uses terms related to clinical finding. So there need to be a uniformity that is accepted. Why? Because in an institution for undergraduate BDS students, we pathologists, medicine and diagnosis specialists used to teach them periapical pathology based pathological diseases based on pathological findings. When they land in the clinical posting, many of the diagnoses that we taught will be deferred by the endodontist. So we need some uniformity. So that is one of the reasons for coming out with this classification. And they need a diagnostic term based on the clinical finding rather than on the pathological finding. That is the first explanation given. A system to help clinician to understand the progressive nature of the pulpal and periapical disease and guide them to the most appropriate treatment. So based on the clinical findings, they need an endodontic diagnosis, and that diagnosis should help the general practitioner or a clinician to make a good, appropriate treatment plan. So that is the second intention. Then the third intention was there should be an accepted terms across all the dental disciplines. This is what I told you. We teach the undergraduate students in radiology, dental radiology, periapical granuloma. When they reach the 4th or 5th year in endodontic clinic, the endodontist may differ with this term, saying that it's a pathological term. So the student will revert back to us seeking explanation. So we need uniformity among different specialty in dentistry. That is one of the reason for this recent classification. In order to render proper treatment, a complete endodontic diagnosis must include both pulpal and periapical diagnosis for each tooth evaluated. So for an endodontic aspect, if you are trying to make an endodontic diagnosis, this association needs a separate diagnosis for pulpal and separate diagnosis for periapical. That is needed. That may help a beginner, that may help a general practitioner, and even a specialist who are planning appropriate treatment. And in case of doubt, general practitioners should always refer patient to an endodontist for further evaluation. So these are the reasons why these two reputed associations have come out with this recent classification, which was published in 2013. So now let us apply both the traditional pathological concept of classification and the recent classification in real life situation. So here is a case where mandibular molar is having a caries, which we have already seen, and there is loss of lamina dura, there is gradual widening of medial space, there is 1 to 2 millimeter radiolucency, and which was surrounded by an diffuse radiopacity both in the mesial and distal. So this is the history. Grossly decayed mandibular right first molar has been sensitive to cold and sweet over the past few months, but the symptoms have now subsided. So this is a clue that the pulp has gone for necrosis. Earlier it was sensitive to thermal stimuli, now it is not. Now there is no response to thermal testing. So when we apply pulp testing, there is no response. There is no tenderness on biting, and there is no pain on percussion. That means it is totally asymptomatic. Radiographically, there is a diffuse radiopacity surrounding 1 to 2 millimeter of periapical radiolucency, loss of lamina dura, gradual widening of adjacent medial space. So all findings are there. So if you ask me for a traditional pathological concept of diagnosis, I would diagnose this condition as a dental caries of 4-6, that is the mandibular right first molar, with condensing osteitis. So why we generally think that diagnostic terms should be precise, concise, and it is informative. So when I say condensing osteitis, I have in mind that pulp and periapical pathology is not a different disease. It is a different stages of the same disease. It is a progressive in nature. So when I say condensing osteitis in dental caries 4-6, what I mean is there is a dental caries in 4-6, which would have involved the pulp. The pulp would have gone for pulpitis. It would have gone for pulpal necrosis, and the pulpal necrosis product would have reached the periapical area. That has resulted in a periapical radiolucency. Now the next stage is the bone has reacted by producing a lot of high density sclerosed bone surrounding the periapical infection. This is what is the pathological concept of diagnosis. But from the clinical point of diagnosis by AAE and ABE, the same thing can be written as dental caries 4-6 with pulpal necrosis. It gives clear indication that the pulp is necrosed. Asymptomatic apical periodontitis. Why it is asymptomatic? Because there is no symptom in the patient. There is no response to the thermal stimuli. Pulp vitality test was negative. Okay, and when you percuss, there is no symptom. So it is asymptomatic apical periodontitis with condensing osteitis. So it is more or like a descriptive diagnosis. So it is given. It is very good from the point of the student and a beginner as well as general practitioner. It gives the status of the pulp, saying that the pulp is dead or necrosed, and it says asymptomatic apical periodontitis. So the patient don't have any symptom, but there is a periapical radiolucency, asymptomatic apical periodontitis, and there is a good response, bone response in the form of condensing osteitis. It is more descriptive in nature. So accordingly, it may help the practitioner for planning a good treatment for the tooth. So the treatment plan would be a non-surgical endodontic treatment followed by build-up and crown, and it is generally over the time gradually the condensing osteitis would regress partially or totally. So this is how the treatment is planned and the prognosis is assessed. Now let us take another situation. So here is a radiograph which we have already seen. There is a root canal treated central incisor, right central incisor. Okay, but the obturation was not good at the apical 1/3. You can see there is no complete obturation. So it has resulted in a well-defined periapical radiolucency there. Okay, size less than 1 centimeter. Loss of lamina dura is there. Okay. Now let us see the history. It is a previously treated maxillary right central incisor. It exhibits a periapical radiolucency. There is no history of any pain, and the tooth is totally asymptomatic. There is no response to the pulp vitality test. Okay, and there is no tenderness to percussion or palpation. So how we can diagnose this in the traditional pathological view? I will diagnose this as a previously treated maxillary central incisor, root canal treated, with periapical granuloma. Periapical granuloma is totally asymptomatic. Why periapical granuloma? Because it is well defined periapical radiolucency, less than 1 centimeter. Okay, there is loss of lamina dura, all fit for periapical. The same can be diagnosed in AAE format like this, previously treated 1-1. So the pulp, we are giving clear indication that this is a previously RC treated tooth, root canal treated tooth. And it is asymptomatic apical periodontitis. Why it is asymptomatic? Because there is no response to the thermal stimuli as well as percussion. And it is apical periodontitis because there is a periapical radiolucency. So this is how we write or we make a diagnosis in the traditional pathological aspect and the recent clinical aspect. Okay, And based on that, it will help the clinician to plan the endodontic treatment for this patient. Endodontic retreatment with the placement of post and core supported permanent restoration is the treatment plan for this. So this is how we based on the AAE and ABE recommendation, a student or a practitioner should write. We should have a separate pulpal diagnosis and periapical diagnosis. So just to, we have come to the end of my video. This is Grossman's Endodontic Practice, 12th edition. And I had the opportunity to be a contributor in this textbook by Dr. Suresh Chandra, one of the legend in endodontics in India, and a very active Prof, Dr. Gopi Krishna. I had a chance to work with him in India, and in the contributor, among the Indian contributor, I had the opportunity. Thanks for Dr. Gopi Krishna for giving this opportunity. I have contributed in the first diagnostic chapter in this issue, and whatever I have learned, I have to thank my mentor, my teacher, Professor N. Gnanasundaram, who has given me good appreciation and encouragement to learn my oral medicine and radiology with a lot of interest. And guys, thank you for watching my video. If you like my video, please don't forget to like, subscribe, and share my video. And if you have any comment about the periapical pathology, please comment in the comment section. Thank you for watching my video. Thank you, one and all.